the first question. One of the questions that we often used to discuss in our Sunday test program is which is the saddle joint, which is the hinge joint and so on. So the first carpometacarpal joint is typically what type? It is classically a saddle joint. The very important thing that we have to examine is the first metacarpal typically will be articulating with the trapezium among the carpal bones, and the fifth metacarpal will be articulating with the hamate, and these two are typically the examples of the saddle joint is what need to be remembered. Whereas if you take the second to the fourth carpometacarpal joint, they are all not saddle joints. They are typically the plain synovial joints is what I want to underscore to all of you. Basically, what is a saddle joint, doctor? It will be permitting the rotation in two different planes. The way you are seeing here. You are able to see from the last, doctor? Good. So it will permit the rotation in two planes. And it will be allowing the movement back and forth, up and down, but it does not allow the rotation. That is the difference between the ball and socket versus that of the saddle joint. Hinge joint will allow the extension and retraction of an appendage. Classical elbow joint you should not basically forget. And you have a ball and socket in the hip and the shoulders, which will allow for the radial movement and the rotation. And there is a gliding joint. Typically it will be allowing the two bones to slide past each other, is called a gliding joint. The mid-carpal and the mid-tarsal joints are the classical examples of the gliding joint. And you have a ellipsoidal joint. It is very similar to that of the ball and socket, but the best example is the wrist radiocarpal joint is an example of the ellipsoidal joint. Then you have a pivot joint. Around the central axis there will be a rotation which will be happening. The classical example is the forearms. You have the radius and the ulna will be twisting around each other. The other one is in the neck, the median atlantoaxial is an example of the pivot joint is what I want to underscore. So finally, what is your confident answer and the correct answer, doctor? It is the saddle joint is what I want to underscore to all of you. The next question is the nucleus pulposus is a remnant of. A wonderful question, because tomorrow as a neurologist, back pain which is not resolving is a favorite complaint that you will come across. Back pain in the 40-year-old lady. You don't know whether it is because of excess work in the kitchen, because of the chronic fatigue syndrome, or is it really because of a dangerous problem like disc prolapse. Now let us talk about this nucleus pulposus. It is a remnant of the notochord basically. What is this nucleus pulposus? It is a gelatinous material that is there in the center of the intervertebral disc. It has got a very high water content because it has got a lot of peptidoglycan molecules is what I want to underscore. What is the purpose of it? All that weight that falls on our vertebral column is basically buffered by this nucleus pulposus, and it also will allow the pivoting for a small joint motion at the level of the intervertebral plane is what I want to underscore to all of you. And nucleus pulposus can actually undergo a herniation because of the breakage of this annulus fibrosus which is around the nucleus pulposus is what I want to underscore to all of you. Whenever we say disc prolapse, it is basically the prolapse of what? It is the prolapse of the nucleus pulposus is what I want to underscore to all of you. So this is basically called a grade 1 intervertebral disc prolapse where only a small amount of nucleus pulposus is herniating. It is much more a severe type, and in this type virtually it is leaking into the surrounding area is what you have to fundamentally remember. MRI. Tomorrow day in and day out your affair is to know when MRI is brought with a patient who has got a back pain whether there is really a disc prolapse or not. So you need to identify, you can see in the center there is a presence of a disc, it is typically herniating, and here you are having the S1 roots, S1 narrow roots. Sometimes this disc can prolapse and invade this narrow roots is what I want to underscore. When it invades the narrow roots, then it leads to a severe excruciating back pain is what I want to underscore to all of you. So finally, what is your answer, doctor? Nucleus pulposus is a remnant of the notochord embryologically is what you need to remember. And venous pump, typically how do you like to define the venous pump, doctor? It is that musculofacial region of the calf, it's called the venous pump, and typically of the vascular system, the venous system has got a valvular structure and the flow is not dependent on the heart, and you are having a superficial vein, deep vein, perforating vein and the intramuscular venous sinuses is what I want to underscore to all of you. So whenever there is a contraction of this muscular pump, then the veins, the venous blood will be pumped in the upward direction. Generally, the contraction can produce the pressure as much as 200 millimeters of mercury. Heart can only produce the pressure up to about 120, at most 140 if you are hypertensive, 160 millimeters of mercury. Whereas you can see muscular pump in the lower limb produces such a very high pressure is what I want to underscore. So what is the classical location whenever there is a varicose veins for the ulcer, doctor? It is along the medial surface of the calf is what I want to underscore to all of you. Let's go to the next question. Vitelline vein, from where does it form? So typically, will it lead to the formation of the portal vein is a very important question. Now I will present you 3 schematics that will solve all your doubts about the embryology of the venous system and the arterial system. Any one of them is going to be the favorite question of the examiner. That's the reason, go back to those Langman days of embryology, doctor. If you look at this legend, what you can see is there is one septus transversarum which is there. You are able to see, doctor? Septum transversarum which is there along the mesenchyme of the liver is what need to be basically remembered. There is one superior vena cava, there is one truncus arteriosus and bulbus cordis, and you are having one right anterior cardinal vein, and the sinus venosus is having 2 horns, the right horn and the left horn of the sinus venosus. Now my question to all of you is, what happens as the embryogenesis happens? All these mesenchymal cells of the septus transversarum will be imposing a vascular change, and that will lead to the formation of the hepatic sinusoids is what need to be basically remembered. And there will be 3 shunts which will be developing. And because of these 3 shunts, the right horn of the sinus venosus become enlarged in comparison to that of the left horn. Similarly, this ductus venosus will be forming one bypass from that of the left venous circulation towards the right venous circulation. And you can also see the Vitelline veins will be combining together to form the portal vein is what has to be basically remembered. So at the end of the whole story, what you have is one ductus venosus, and this is starting from this left umbilical vein, and you are having the superior vena cava, you are having one major left brachiocephalic vein, and there are a lot of vessels. Typically the Vitelline veins will be contributing for the portal vein formation is what I want to underscore. So that's the reason, doctor, what is your final answer? The Vitelline veins will be forming the portal vein is what need to be remembered. So for the benefit of all the juniors, let us quickly review some of the favorite questions which are going to come in the tomorrow's exam in relation to this topic, doctor. Anterior cardinal vein will be forming the left superior intercostal vein. Left common cardinal vein will be forming a classical vein in the left atrium called oblique vein of the left atrium. And the left posterior cardinal vein will be disappearing. From there is a coronary sinus, a very important venous drainage that the heart is deriving from. It also is from the left horn of the sinus venosus is what need to be remembered. Now we have some major vessels, superior vena cava, inferior vena cava and so on. From where are they deriving from, doctor? Superior vena cava will be having the origin from the right anterior cardinal vein and the right common cardinal vein. These 2 things will be giving, right common cardinal and the right anterior cardinal vein will be giving rise to the superior vena cava is what need to be basically remembered. And the primitive atrium will be giving rise to the right auricle. The foramen ovale will be leaving the fossa ovalis, and you are having a lot of aortic arches. What are derived from this aortic arches is another favorite question of the examiner. First aortic arch will give rise to the maxillary artery and also to the external carotid. Second aortic arch artery will be persisting as this stapedial artery. The third aortic arch will be forming the proximal part of the common carotid artery. And the fourth aortic arch will be forming the ascending aorta, whereas the fifth aortic arch will be disappearing, and the sixth aortic arch will be giving rise to the left pulmonary artery and the right pulmonary artery is what need to be remembered. That's the reason, doctor. In the tomorrow's exam, aortic arch derivatives and embryological remnants and what is their adult counterpart in the venous system, one question invariably is going to come in any exam you go. Finally, ductus venosus, that classical thing which you see in the septum transversarum of the liver. What is it going to give rise to, doctor? It is going to give rise to the ligamentum venosum in the final part is what I want to underscore to all of you. Let's go to the next question. Os paralysis. Is it upper or the lower brachial plexus, doctor? Upper. Wonderful. Now you need to know what is the ported tip position, then you can simply answer this question very easily. What you need to know is there is a painless, in this illustration you can see, a painless left and upper arm paralysis is there, and the left arm is extended and the baby is unable to flex it. So he loses the opportunity to flex. And also the forearm is turned inwards with the hand and the palm rotated outwards, resembling the weighted tip position is what need to be basically remembered. So there is a reason, doctor, internal rotation or is it the external rotation? Which is the one which become affected in the case of the Erb's paralysis is a very important thing that you have to basically understand. What is happening in the ported tip position, doctor? Is it internally turned or outwardly turned? Internally turned. So it is possible motion is what I want to underscore. That's the reason exit becomes the B is what need to be remembered. Let's go to the next question. Pharyngeal plexus typically supplying which muscle? Now this is another favorite question, doctor. Laryngeal and pharyngeal motor and sensory supply, invariably one question is going to come, any exam you are going to write. So please remember, all the muscles of the pharynx are supplied by the pharyngeal plexus except the stylopharyngeus is what need to be remembered. It will be deriving from the glossopharyngeal nerve basically. And all the laryngeal muscles will be deriving the innervation from the recurrent laryngeal except the cricothyroid, which is controlled by the external laryngeal nerve, is what I want to underscore to all of you. Now coming to the sensory supply, another favorite question of the examiner. Internal laryngeal nerve will be supplying everything above the level of the vocal cords in the larynx, and the recurrent laryngeal nerve will be supplying all the sensory supply below the level of the vocal cords is what need to be remembered. And basically these both are the branches of the vagus nerve is what need to be remembered. Coming to the pharynx sensory innervation, most of the pharyngeal sensory innervation derives from the glossopharyngeal nerve and mostly from the pharyngeal plexus, but the mucous membrane of the nasopharyngeal part, it comes from the maxillary nerve is one small exception that need to be remembered. And basically all the laryngeal nerves, whatever be their name, are derived from the vagus nerve, whereas the pharynx will be deriving not simply only from vagus, it has got multiple nerves which are basically innervating it. So differences between the innervation of the pharynx and larynx is a favorite question from times immemorial. Do you think it is an atypical question in yesterday's exam? No. That's the reason, doctor. A prepared mind will think exam easier. A less prepared mind will think it is tougher. So that's the reason it is we who are reflecting to it, not the exam which is really happening. So let us not give a relative importance to this.